this a little bit. I was asked to talk a little bit about robotic approaches to esophageal surgery. I'm a thoracic surgeon at a cancer center, so what I'm going to be talking to you about is basically robotics as applied to esophageal surgery for tumors. So I won't be talking on fundoplications, etc. We began our robotic program in 2011. The majority of what we do with the robot is mainly lung-based. Foregut accounts for about 20% of our practice. In the 3.5 years since we initiated our program, we've done about 30 esophagectomies and then about 3 or 4 myoma resections. So I'm going to talk to you about today robotic esophagectomy, first described by Santiago Horgan when he was up at University of Chicago, a transhiatal approach, which is where you approach the esophagus from the abdominal approach, dissect up through the posterior mediastinum, make the conduit in the abdomen, and bring it up in the posterior mediastinum with an anastomosis in the neck. Nowadays, since most of the tumors that we see are in the lower esophageal, around the gastroesophageal junction, the commonest operation for esophageal malignancy is an Ivan Lewis. That's an operation where we do a 2-field approach, one in the abdomen and then in the chest, which is where we make our anastomosis. And this is from the Memorial Sloan Kettering crowd. It shows the abdominal approach using the robot first to create the conduit, followed by turning the patient on their side and approaching the chest through the right chest to perform the resection of the esophagus and the anastomosis. So I'll just sort of run through the general setup here. This is the abdominal trocar placement. The head is at the top of the screen, feet are down towards the bottom of the screen. Patient's right is on your left. We use typically 4 robotic trocars plus an assist. This shows the newer generation XI coming in, which is quite nice because you can bring it in just laterally and then rotate it. We begin with creation of the gastric conduit, celiac axis node dissection, and mental flap. This is as close as I get to microvascular or plastic surgery, my mental flap. And basically what we do is we elevate the omentum off of the colon and then get into the lesser sac and create a little segment of omentum based on the right gastroepiploic arcade. Here it is, just dividing the omentum. And I will tell you that I think this is probably easier done with conventional laparoscopy than with a robot. The robot is really good for small confined areas. When you're moving around a lot, I learned about scaling yesterday talking to Benoit. It can be a problem. So once we've made the omental flap, then we start dissecting the short gastric arteries up along the greater curvature. This is the left cruce that we dissect out. And then we go over to the lesser curvature side, divide the lesser curvature tissue. Let's speed it up here. This is the left gastric vein. And again, the robot is absolutely perfect for this. In the old days when we were doing these minimally invasively using conventional laparoscopy, we wouldn't really even identify the arteries or the veins specifically. We just fire a big old stapler across all that. So this is a lot more accurate, in my opinion, and I think we do a much better job at nodal dissection and making sure we're truly getting all of the nodal tissue from that. So we'll dissect these all the way down to the origin of the left gastric artery with the celiac axis. You see the left gastric disc being divided there. And then we create the gastric tube. This is created using serial applications of staplers. Nowadays we're using the robotic automated stapler to do this. We create a long tube that then will be used for bringing up into the chest. And then the last thing we do is dissect from an abdominal approach up into the chest. And again, the robot gives us fantastic visualization up into the chest cavity. You can almost dissect up until the carina. Again, very good at getting nice radial margins there. We're able to dissect right on top of the aorta there and below the pericardium, as you can see at the top here. Pericardium. So then once we've created the gastric tube, then we move into the chest, position the patient with the left lateral fused position, so his right side is up here, he's facing towards us here. You approach this, placing your ports slightly anterior. You've got to have the camera slightly higher in the chest here because you're going to be making your anastomosis quite high up in the chest. And this is a brief illustration of this. So we began by incising the pleura anterior to the course of the esophagus, so the head is up here, feet are down there. This is dissecting around the area of the carina. Esophagus vein you can see in here. And so we'll resect, we'll do an en bloc esophagectomy here. So we're taking all of the fatty tissue and the lymphatic tissue to the level of the aorta there. You can just see we're just coming across the thoracic duct, which we take en bloc with the esophageal specimen. The esophagus has been mobilized here. We're dividing it. Then we move through an endocatch bag. Now, I think the most critical part to success in this operation is a perfect anastomosis. And this is the Achilles heel of standard minimally invasive techniques. But it is where the robot excels because of the dexterity that we have. And the creation of this purse string is probably the single most difficult thing that we do when we do a minimally invasive esophagectomy. But it's actually relatively straightforward with the robot. As you can see, it's akin to doing what we would do in an open fashion. So we create a purse string suture and then perform a stapled end-to-side circular stapled anastomosis. So there we've done the purse string, we cinch it down. Then we make a little hole in our stomach conduit at the tip. Put this big old ILS stapler in, and then create the anastomosis. And there's our mental flap that we bring up, and we wrap that around. It's kind of like a burrito. We wrap it around, completely around the esophagus. We want to protect that esophageal anastomosis. If there is a leak, the omentum will usually seal it. And we've shown in open series, at least, that this significantly reduces the incidence of esophageal leaks. So this is a patient that we did about 2 weeks ago. It's just showing the post-operative incisions about a week out. The advantage of the robotic approach as I see it, we talked a little bit about this earlier, but fantastic dexterity. I mean, this is the left gastric vein as it comes down onto the portal vein there, not an area you want to get into bleeding, but it's very, very easy to dissect that out extremely accurately with the robot. I'm just going to skip over some of these here. Occasionally we'll see a replaced left hepatic artery. This is an guy that we did last week. And again, you want to replace that replaced left hepatic. The replaced left hepatic comes off the left gastric instead of the common hepatic. And so here we've skeletonized the left gastric and we've divided the branch just to the stomach here, preserving the replaced left hepatic. This is an area, the enhanced visualization techniques, where I think the robot really excels. We're experimenting now and investigating the use of indocyanine green for identification of sentinel lymph nodes. So we inject preoperatively indocyanine green in the region of the tumor, and then we go to the abdominal phase. We can see where these lymph nodes light up in the lesser curvature tissue. Whether or not this actually is going to make a difference in terms of cancer recurrence, I don't know. We're investigating this right now, but it does at least ensure that we resect the draining lymph nodes. Infrared imaging or near-infrared imaging of the gastric-pleuric arcade. This is an important thing. These little arcade branches, collateral branches at the junction between where the left and right gastric-pleuric artery goes in and the short gastrics begin, can sometimes be very difficult to visualize. ICG allows us to see these tiny little communicating branches so that we can know where their path is, so that we can resect the omental tissue far enough away and not destroy them. And then lastly, demonstration of how we use ICG to determine the vascularity and perfusion of the gastric conduit once we've made it. So once we've created our conduit, we have our anesthesiologist inject about 10 milligrams of ICG intravenously, and you see this beautiful highlighting of the gastroclephoid arcades. But what you'll also see is that there's an area at the tip of the stomach that is not getting good perfusion. And so knowing where that line of demarcation is allows us to place our anastomosis at a better perfused portion. So we are early, I would say, in our experience. We've done a total of 30 cases. We've analyzed 26 of these up until March of last year. The majority were Havel Lewis. We've had a pretty high conversion rate, and I don't apologize for that. I think that's a good thing. I think it's good to be careful. Most of these were fairly advanced stage patients, stage 3, R0 section achieved in all patients. Bottom line is when we compare these to over 500 open cases done during that time, we didn't see any significant difference in terms of patient demographics, nor do we see any difference in terms of pathologic tumor stage. We resected a mean of 26 nodes compared to 24 open. That's not significant, but at least we're doing a good lymphadenectomy. Hospital stay is probably a little shorter, although it wasn't statistically significant in this with these small numbers. I would say that the surgery takes a lot longer than open approaches, and it takes a lot longer than standard minimally invasive approaches. And I think that's partly because we're fairly early still in our learning experience. Importantly, we've had no 30-day or 90-day deaths and acceptable morbidity. A little bit early to look at long-term survival, but again, on these 26 patients, we didn't see any significant changes compared to open. These are the total series of patients that have undergone a robotic approach in the literature. You can see there's different techniques, whether or not you do a 3-hole technique, where you're doing abdomen, chest, and neck, or a transhiatal approach, where you're doing just abdomen and neck, or the Havel Lewis, which is chest and abdomen, obviously. In comparison to aggregated sort of summaries, I think we're sort of on par with what has been reported in the literature. 100% R0 resection. Most of our patients end up having preoperative treatment. Again, slightly higher conversion rate, but a very low leak rate, only 4% leak rate in our series, and 0 mortality. So in terms of surgery for other tumors, as I said, we've resected a couple of leiomyomas, and the robot is really fantastic for this. I'll just give you a brief example of one case. This is a guy who came in with this posterior EG junction leiomyoma, which is a difficult area to get even open, to be honest with you. But the robot allows us to get in under the vessel curvature, elevate the stomach, incise the back wall of the esophagogastric junction there, and just enucleate that thing, really. We're really able to preserve the underlying mucosa, and all we do then is just oversew the muscularis. So this patient got a swallow test the next day and left the hospital on post-op day 2. So in summary, I would say that robotic esophagectomy certainly is feasible compared to our experience with open esophagectomy, which is the benchmark. It has equivalent safety profile, I would say. It does take a little bit longer. However, I expect that operative times will improve with experience. And I think that clearly it has some advantages over standard laparoscopic and thoracoscopic approaches with respect to the accuracy of dissection and the enhanced imaging abilities that it has. So